Great pleasure to introduce my friend Kristin Knudsen, who's an epidemiologist from Norway. She's based in Bergen and works at the Norwegian Institute of Public Health. And Kristin and I ran past each other when we were out jogging yesterday. So those of you who want somewhere nice to jog in Aarhus, you must go to Risko, and we were both up near Risko yesterday, and apparently Peter de Jonge was jogging through there as well. I particularly wanted Kristin to come along because she's at the cutting edge of, she's doing something that I dream of doing, where she's actually doing surveys in Norway. It'll be linked to cohort studies like the Hunt and registers. So this is this is clearly virtuoso epidemiology. And Kristin's also involved as a member of the World Mental Health Survey, which is Ron Kessler is a named investigator on this project. And so I'm looking to our neighbours in Norway to give us inspiration for the next generation of psychiatric epidemiology. And Kristin.
Is this on? First of all, I'm so happy to be here, so thank you so much for inviting me. Not on? Hello?
Yes.
One professor and one doctor could finally figure it out. Okay. So what I was saying, thank you so much for inviting me. It's really here, and I hope that this will be the start of a long-time collaboration where we can do comparative and collaborating studies using Norwegian, Danish. Okay?
No.
Can you hear me?
No, no.
Okay.
Like this.
Hello?
Yes.
Hi. Very good. Let's see if this is working. Yes. Okay. So I will talk a little bit about how we use GBD results in Norway, and also a little bit about the expansion, hopefully, of how we can use the results in the future. So when I was giving the topic of this talk, I started thinking about what I could compare it with, and what I was thinking about was this Viking king we had in Norway in the late 1800s, who traveled around Norway, which was then dominated by petty kings in different parts of the country, and he unified Norway into one kingdom. So he's one of our famous king. Harald Hårfagre, his nickname Hair Fair, because he said that he will not cut or wash his hair or comb it until he had gathered Norway into one kingdom. And of course, this is a legend, so it was not that easy, as it says in the legend. So, what did we know about global health before the Global Burden of Disease project? And this project was built on the premise that all humans should have the chance to live a long life in good health. And before Global Burden of Disease, there was widely different estimates on disease burden from different sources, and most of all they were preoccupied with deaths, with number of deaths. The problem was that when you combine all these sources of deaths, they usually was more than 100%. So one of the first thing that the global GBD did with Alan Lopez and Chris Murray was to say, okay, we can't have more than 100% deaths, so we have all-cause mortality or total mortality, and we have to put these deaths down to the appropriate diseases. And that's kind of easy when you have deaths, because you know more or less how many people have died, but it's so much more difficult to count the number of people who are ill and still alive. So before GBD, we had no knowledge of the disease burden caused by non-fatal illness. So what Alan Lopez and Chris Murray set out to do was to build a roadmap that could sum up all the global deaths and the non-fatal health loss and map them to diseases and risk factors. So this was at the global level, and in Norway we have more or less the same problem. We have several high-quality health registries in Norway. Actually, one of the first health registries in the world was developed in Norway with a leprosy registry, which was established in 1856. And we also have the large population-based health service. We have decades of tradition of collecting health information in our population. So in terms of causes of death, we have quite good overview due to the Norwegian cause of death registry, which was established in 1951. But our knowledge about risk factors and other diseases, that was more sporadic and often driven by different researchers or medical doctors, particular interest in different fields. But then in 2010 something happened. Well, not in 2010 because it was in 2012 the publication came, but with GBD 2010 for the first time we got information about a complete picture of public health in Norway with the publication of GBD 2010. So this gave us for the first time the overview and the possibility to compare between diseases, the disease burden caused by different diseases, both in terms of non-fatal health loss and fatal health loss, for injuries, and between countries, between sexes, between age groups, and across years. And also risk factors, I forgot to put that on the list. So this was, GBD 2010 was met with considerable interest in Norway. But the GBD 2010 results were not available in Lancet publication, but they were published online with the visualization tool. And in 2013, the Norwegian Burden of Disease project was established, and I was employed as one of the researchers on that one soon after I started. And our head at that time, Stein Emil Voldseth, he was very good at convincing both the politicians but also the Norwegian Institute of Public Health of the importance and usefulness of the GBD results, which led to that it was decided that we should not only be a project, we should be a center at the Norwegian Institute of Public Health. And what the politicians hoped to get out of this was complete health statistics, to do international comparisons. As you know, it's probably that for most countries, but in Norway we like to brag about how good we are at skiing and winter sports, which most and nobody else, no other countries really do, but we are the best at that. We suck in football though. But to do the international comparison and also to do the regional or the subnational comparison and over time to see how it evolved was considered very important. And they also wanted to use the GBD results as a tool for prioritizing and for planning and prognosis. And it has taken a bit of effort to get the point through that you can't do prioritizing based on GBD results alone. As Dan said, you also need to know something about the cost effectiveness, and you have to have the effective interventions and so on. And for some diseases which we have very low disease burden, such as the communicable diseases, HIV, tuberculosis, and the diseases that are more or less eradicated by our vaccine programs, they could easily come back if we stop doing investments in those. And they also wanted to use the GBD results as a tool for evaluation of the effect of the interventions. So the Center for Disease Burden at Norwegian Institute of Public Health, it was established in 2015, and we work very closely together with the IHME, where GBD is placed. In fact, our founder of the center, Stein Emil Voldseth, he has now moved to Seattle to do the projection analysis for coming iterations of the GBD. And we have close collaboration with national researchers who are interested in disease burden and also with international research. And I hope by being here also I can work even more closely with those of you who are interested in. So please approach me at the cocktail hour today. As I said, we started in 2015, and from that on we have had several publications, mostly on national level, in terms of national reports, because the GBD results has been met with so much interest. We have focused on writing Norwegian reports, presenting the Norwegian results in much more detail, and also inviting other Norwegian researchers on different disease topics to comment on the results and give their input, and also critique on the results is important. And the result from this has been used politically. I want to mention specifically one. In one way it has been used. It's the government strategical plan for how to improve mental health of Norwegians. And the GBD results on anxiety and depression and on how much disease burden that was caused by them was particularly used as an argument for improving or focus on mental health services and prevention of mental disorders in Norway. This came out earlier this year, so we're very excited about how this will be followed up by the politicians in the future. So in Norway we have 3 goals which are very similar to not only the Sustainable Development Goals but also goals made by the WHO. And disease burden estimates can be used to inform how we're doing on these goals. So the first goal is that Norway, we used to be the country in the world with the highest life expectancy in the it was so far back as 1950s, 1960s, but we still think we can be there again. But as you can see from this table, this is life expectancy calculated in GBD 2013. We're quite far down the list. We're on ranked as the 15th country in the world for women and also for men. But the span to the highest country is not that big, and it could be achievable, but I'm not sure. There are some discussions on how good this goal really is, because if we are to be best, someone else has to do worse. So I personally, I don't think this is as a very important goal that we should use a lot of effort on. The next goal, on the other hand, is that the population shall experience more years with good health and well-being. So it's not how long you live, but how good you live while you're still alive. And from the 1990 to 2016, we have had an increase in both life expectancy. This is for both men and women, but also what you call healthy life expectancy, which is a GBD measure where you take life expectancy and you subtract the DALYs for each age group. So as you can see, we have also had an increase in healthy life expectancy, how many years you can expect to live with good health. But this has not been with the same rate as life expectancy. So actually the difference between life expectancy and healthy life expectancy is increasing. And that is concerning. And that is something we should do something about. The third goal, we shall create a society which promotes health in the whole population and which reduces social health differences. We can also use GBD results on estimating some of this. For instance, looking at age differences in DALY. These are the same in Norway as other high-income countries. We see that for the younger population, mental disorders is the largest cause of DALY. For the middle-aged is the musculoskeletal disorders, and when they reach 50-60, the neoplasms, the cancers, and the cardiovascular diseases are kicking in. And also sex differences, much more depression, anxiety, and back and neck pain among women, but men are more affected by ischemic heart disease, stroke, and drug-related disorders. It's also part of the good health for the whole population. We, for GBD 2017, has done a subnational analysis for Norway. They do subnational analysis, I think, for each country with more than, is it 200 million people? Yeah, and for Norway, who's got 5 million. So for some of these counties, at least the one high up in the north, there are not so many people living there, but we will have these subnational results now, and we're very excited about that. Also, we have a project going on where we shall look at disease burden due to different socioeconomic strata, using both GBD results, but also using our own data in that one. So, apart from giving us an overview of the Norwegian public health, giving evidence that Norway is not best in class for life expectancy and healthy life expectancy, showing the significance of cause of death in young age, the contribution of non-fatal outcomes, providing directions for which risk factor we should focus on, etc., etc. What has GBD ever done for Norway? So, another important aspect about collaborating closely with GBD is that you get a different view of your own data. Because we used to think that we have very good health data, we have complete registries, and so on, and GBD shows us that, no, it's not good enough. Some of our studies are not included in GBD because it lacks quality. For instance, the use of the GBD use of so-called garbage codes, which are causes of death codes that are not valid underlying causes of death, shows that we have a job to do. Almost 20% of the deaths registered in Norwegian cause of death registries are so-called garbage codes, which are not useful and has to be redistributed to other causes by the GBD. And it is, this is something that we started working on now after we joined the GBD to improve the quality of our cause of death registry. The next thing is that we have been much more focused on what we want to include in our health surveys. When health surveys were planned earlier, the researchers were up to coming with a project and including them in the health surveys. And I think for the future we will be more focused on getting, for instance, good national estimates of important risk factors, such as smoking, alcohol use, in some cases diet, physical activity, and so on. And we now want to include the measures of these risk factors that are comparative with what are used in GBD and are considered the gold standard. Also, the mere existence of data turned out to be a problem. And for me, I'm a psychologist, and I've been trained in psychiatric epidemiology, and for many years I have wanted Norway to do a proper diagnostic-based survey of mental disorders, which means that you can't have people ticking off on a questionnaire. You have to ask them, you have to sit down with them and interview them about their mental health to get proper mental disorder diagnosis. And some people meant that the registries were good enough for this. So it has not been a priority, because we do have registry on primary healthcare and we do have registry on secondary healthcare. And some people thought that this was good enough to measure prevalences and incidences. And then we met with Theo Voss at GBD in March 2014, and he could tell those people that these registries are not a valid source of information about the prevalence of mental disorders. And as Dan showed you before me, the reason for that is that people don't seek help. They don't go to the health services. We have, in the best case, we have maybe 60% coverage in the health services of people with anxiety or depressive disorders. So, but we really don't know because there hasn't been, at least in Norway, there hasn't been any good studies showing health coverage of people with mental illness or health service use. So based on this and based on the critique actually that Norway received from the Global Burden of Disease study, that we should be ashamed that we haven't done a proper mental disorder survey. This was taken into the public health white paper that came a few years ago. Voila, we got money to do a real proper mental health survey using the composite international diagnostic interview. So in this one we will collect interview data information on mental disorder diagnosis. We will do, in first round we will do 2,000 interviews in connection with the Hunt4 survey. The Hunt4 survey is a large population-based health survey who's now arranged for the 4th time in, I think, 30 years or something, 40 years. With, I think, around 100,000 persons are invited to join in. So, by doing it in connection with this interview, we can not only get the diagnostic information, but we can link this information with the whole Hunt4 survey and the previous iteration for that, back to mid-1980s. In addition, we can also link it with all the health registries and the registries on social security services. So for what we would like to do later, and we will also need like 20 PhD students or so in helping us with this, is to use the GBD results, but also expand them to include functional outcomes by using Norwegian registries, such as comparing disease burden with educational attainment, with the family establishment and fertility, work disability, such as unemployment, sickness, absence, and disability retirement. Hopefully this can inform some of the information that we need for doing good cost-effectiveness studies, and also for health service use and healthcare spending. And one example is from my own PhD, where I looked into what we call years of work life lost due to mental disorders compared with other disorders. And we found out that people who got a disability pension award, which means that they're permanently out of the work life due to disability, for a mental disorder, they receive this in much younger age than for instance, musculoskeletal disorders or all other disorders and diseases. So on average, a person who got a disability pension award for a mental disorder lost 10 more years than for the other diagnosis being in the work life. There has also been, it's not like I suppose Harald Hårfagre also experienced, that it's not so easy coming in and say, okay, come all and we will join in a happy family. There have been some critique, strong critique against GBD from people in Norway as well. Harvey was mentioning this, so in terms of the disability weights and the comparison they do between non-fatal health loss and mortality. And also the former director at the Division of Mental Health at Norwegian Institute of Public Health has argued quite strongly that the mental disorders is still severely underestimated in GBD. But we have nothing better. So this is the best we have, and we should just doing what you're doing, John, and try to develop better methods and convince that they should use those instead. So to summary, sorry, whether there has been a unification around GBD results in Norway, well, we're not totally there yet, but we have a very high and increasing interest of GBD results. And this has contributed to particularly increased attention to the burden due to mental and musculoskeletal disorders. And we find that the media and the politicians and the health authorities, they really like these results because it gives them a very potent visualized map of what to focus on. But we also meet some resistance among researchers, often because they don't like the results for their disease, but also sometimes because they don't understand the methods and they don't understand the thinking behind GBD. So a lot of our work at the center is going out and telling people about the GBD and teaching them about the methods and so on. And also, I think many researchers, they are concerned that due to the imputation done in GBD, there will be no more use for raw data anymore, which are quite the opposite of what is true, right? Because GBD wants the raw data, and that is kind of one of the messages that we are trying to get out. So yeah, that's how we do it in Norway.
Thanks, Kristin. It's not easy getting a big survey set up. Like, how many years did it take you to get the?
Oh, many years. Yeah, 10 years or so.
Yeah, so this is like forward planning.
Yeah.
We've got a couple of minutes for quick questions for Kristin. Jakob up the back, just wait 2 seconds. Microphone.
Thank you for this very interesting talk. I was just wondering, one concern about doing these surveys would be the participation rate, and you would be concerned that participation would be much lower for people with mental disorders.
Yeah, that is a real concern, and also because these are very time-consuming interviews. But what we have gotten approval to do, ethical approval, is that we can link the information on both participants and non-participants to the health registries. So we can actually compare non-participants with participants in the health registries and see how much more ill health do we find among the non-participants, and we can use that as a weighting to weight up the results.
Now, just before we thank Kristin for her presentation, now need to all go through migrate out and go down those big staircases, the fantastic royal staircase. Bergen mural. Going to get a quick group photo. Rora's on his way out there now. And Yetta Bang, you're not allowed to let anyone have any food, okay? So the food will be guarded. So after we thank Kristin, please come straight out for the photo. Then you can have lunch. We'll be back at 1:30. But please join with me and thank Kristin for her presentation.